everyone. This is Shadi Reis from SCAI 2024. I'm really privileged today to be with Dr. Alice Jacobs, who is the Founders Lecturer for SCAI 2024. Thanks for being with us, Dr. Jacobs.
Thank you.
Very important topic that we are going to present on the Founders Lecture is about from concept to clinical, how to create a STEMI program. We have a lot of challenges. Even we think we are ready, but I think there's heterogeneity in the systems. So tell us about the talk and some of the headlines.
So when I was initially invited to give the Founders Lecture, which is a real honor that I very much appreciate, I was asked to speak about the history of Mission Lifeline, which is really chronicled in the American Heart Association's development of systems of care for patients with ST segment elevation MI. And Mission Lifeline was really a story about, system implementation.
Yes.
It was fueled by the fact that we have evidence-based, life-saving, guideline-recommended therapies that we cannot give to all patients at all times.
Correct.
So I'm hopeful that with this lecture, the audience will come away with understanding the complexity of STEMI systems of care, the multidisciplinary involvement that is necessary, the working together of the referring or non-PCI hospital with emergency medical services or EMS, and then the STEMI receiving hospitals working together within regions, and then really have the systems work to their capacity, because I will present the data that shows when you achieve the measures as recommended by the guidelines, mortality is significantly decreased.
Absolutely. So what is your aim for the audience to take away from your talk?
So the challenges that I will discuss, first I will review the progress that was made in the initial years, and then show that the progress has slowed in the past few years, and there are many reasons for that. One is the pandemic and the financial and staff strain on hospitals. Another is that we think maybe the problem is solved because so many hospitals are good at the door to balloon time.
Exactly.
And then recently it's been more difficult to show that as you decrease time to treatment, mortality decreases further, and that's probably because the patient population has changed. So if you look patient to patient, time and mortality are still related. But if you look on the population level, that's now sicker with more patients presenting to the hospital surviving. So with cardiac arrest, mortality is increased. So I think all of those things have put some laxity in the system.
Absolutely. So how do you envision the future?
So I'm hopeful that the next generation, as we march forward, will realize the importance of beating the metrics, and they will put effort into educating our patients, not only our patients, but patients' families and caregivers. One of the most disappointing things is that if you look at first symptom onset to first medical contact, it's 120 minutes for patients who walk in, and it's 80 minutes for patients who call EMS. And we always talked about the golden hour. If you really reperfuse and open the artery within the first hour, sometimes you can abort the MI. So really, and educate them not only with the importance of time to treatment and signs and symptoms, but to know their community so that they know which hospital they want to go to when EMS picks them up, because not all communities have a destination protocol, so that they go right to the STEMI receiving center. And then I hope that they will work together within their systems and their regions, importantly in the regions, to implement strategies that will have us meet the guideline recommended time. And there are many strategies like that. You need pre-specified algorithms for treatment and diagnosis, not registering the patient until you understand that they're having an MI and treat their symptoms, have a designated place in your emergency department to perform the electrocardiogram and have it read immediately, have all patients that need to be transferred be accepted even if the hospital's on diversion or there are no beds, single calls, simple transfers, so no intravenous as you're transferring the patient, no IV infusions, many strategies like that, and then really focus on more granular metrics such as ED dwell time in the receiving center, door in, door out in the transferring center, the time it takes from when you recognize the MI on the EKG in the transferring center to calling interfacility transport, and so forth. So we are optimistic that together we will re-energize the system and make the progress start to escalate again.
So for sure, I would like to recognize that there's a lot of work done in that space, which this next generation should make it easier to fine-tune and also find the gaps and differences in programs and try to learn from other programs to make sure they meet the metrics that you are aiming for. Dr. Jacobs, thanks so much for your time.
Thank you very
and congratulations
much.
For the lecture.
Thank you.
Please watch his videos and others on SCAI-TV. This is Shadi Reyes from SCAI 2024 in Long Beach.